this is a very hard act to follow. I think the presentations that we've heard this afternoon are fascinating to me, and I think there's a level of sophistication and complexity to what we've heard this afternoon that makes me feel that this talk is really very simplistic by comparison. But Claudia asked me to talk about it, so here I am. In our country, and perhaps in other European countries, but it's definitely the case in the United States, there is a relatively simplistic attitude about patients' approach to complex decisions. There are guidelines that dictate what types of treatments people ought to get based on various parameters, age, gender, risk factors, and so forth. And rather simplistic approaches to how people should make those choices. Typically in the consultation between the doctor and the patient, it happens in a single consultation or office visit, as we call it. In our country, averaging about 10 or 15 minutes for a typical primary care consultation. The patient is told what particular treatment is recommended or what treatment options should be considered. An attempt is made to provide information about those choices, and presumably a decision is made. And we all know that's not really how the process ought to be, or frankly how it actually happens. Certainly for complex choices, patients need time to educate themselves about the condition that they're being treated for, learn about the different options, and go through what we call a decision journey to figure out for themselves which choice is best. But we really don't know very much about what that decision journey looks like. And this is a very rudimentary study that we did to try to begin to start looking at this. The complex decisions we were looking at for this study are around cancer screening, but really this could apply to any kind of complex decision. So first, acknowledging lots of co-investigators that helped with this project. And let me just begin with the problem. I've already summarized a lot of this, but one point I want to emphasize is that we have traditionally thought of the process of helping patients to think through these decisions around the clinical encounter as the focus of where that happens. And we are probably entering an era where we need to escape from that paradigm and think about the larger process that patients are going through in making decisions and figure out where the clinical encounter fits into that, rather than trying to in the medical model, think of it through the lens of what happens during the clinical encounter. So the project that I'm telling you about was funded by an agency in the United States called PCORI. It was a 2-year project. The specific aims are laid out there. The idea was to try to reach patients outside the clinical setting rather than waiting for them to show up for an office visit. Identify patients who were eligible for cancer screening, then begin to understand the process they go through in thinking about their choices. And rather than doing it the right way, the way most people in this room would probably want to go about understanding how patients are going through this process, we used a very simplistic method, which is to take advantage of a portal connected to an electronic medical record. Now, I believe when I mentioned this to Claudia, she said that portals are not commonly used here in Switzerland. Do any of you recognize that term, portal? Okay, so let me just explain what that is. In the United States, a lot of doctors have switched over to electronic medical records rather than paper records. So the clinical providers, the doctors, the hospitals, are all connected through these electronic systems. But increasingly, they're trying to make that system accessible to patients. So patients can make use of a portal, which is a web-based site that they can go to look into their clinical record. And it's typically pretty limited at this stage. So you can look at your lab results, you can see some summaries of your office visits, you might be able to see your x-rays, you may be able to communicate with the doctor, send questions, or schedule appointments. We took advantage of a portal like this to do something much more proactive, which is to reach out to a population of patients that we identified and try to develop an interface for them to try to understand how they go about the process. So if I can get the pointer to work here. The idea here was this portal, which they are normally using already, would identify people who were potentially eligible for cancer screening. I'll explain what that means in a second. And then have them answer a series of questions. And based on how they respond to those questions, give them customized information about the choices that they have available. That gives them an opportunity to do research on the decision-making process. And then some of what they end up concluding can then get passed on to the clinician, who at the time of the consultation can be aware of that information ahead of time. And some of this is basic information. Some of it would fall under the category of expectations. What are the patient's expectations? What are their concerns? What are their fears and worries? We actually did audio recordings of those visits so that we could see whether the visits changed. And then we had post-encounter surveys completed by the patient and the clinician afterwards. So we had data coming from various sources for this. So this is what the portal looks like. So typically, if you were a patient, you'd go to this to find out. This is oriented around preventive services, meaning screening tests, health promotion activities, immunizations, and so forth. But you see, you can look up different information about yourself. But if you fell within one of those three categories of eligibility, and those three categories were men over age 50 who were potentially eligible for prostate cancer screening, women over age 40 who were potentially eligible for breast cancer screening through mammography, and men and women over age 50 who are potentially eligible for colon cancer screening. We identified all three of these because they're controversial, at least in the United States, as to whether that kind of screening should be done. And if you fell into that category, this prompt would appear that would invite you to complete this portal or this module called My Questions was the name given to it. But it's a series of questions that basically are meant to try to understand where the patient is coming from. So the first screen that you would see would look something like this, in this case about colon cancer screening, saying you have a decision to make about colon cancer screening, give you some background about the information, and then hit you with a series of these 17 questions, beginning with how far along are you with making the choice. All 17 of the questions are shown on this slide if you want to get an idea of the kinds of questions that we were asking at. But what you'll see here is not only an attempt to try to understand where in the decision journey people are in thinking about this process, but to try to get a sense of what their key questions are, how they go about getting information, what ways they like to see their information organized. On the issue Paul raised, what kind of fears or worries do they have? What are the types of steps they want to take next? This is, in our view, basic descriptive information about how people go about making decisions. There's not a whole lot of data on it. There's a lot of limitations to these data that I'll tell you about, but it was an attempt to try to dip into that topic area and try to get more information about it. There is a question that patients come to at this point where they ask whether you want to discuss this the next time you visit your doctor. And if they say yes, the electronic system automatically forwarded the answers to their questions to the electronic medical record of their doctor. So a summary of their answers to these questions then arrives to the doctor so that when the doctor next sees the patient, they have that information in front of them. We began with a relatively large sample of patients who answered this. You can see their demographic characteristics here. And what I'm showing you are some of the data that began to come back from this study. So first of all, that first question about have they ever heard about the screening, you see this is a population that is generally more knowledgeable about the screening test. This study was done in a location in the United States with a relatively educated and knowledgeable patient population. If we'd done it in other parts of the country, that would not have been the case. Many of them had heard that they should be screened, and most of them had heard about this from their doctor, but they had heard about it to some extent from other sources. And then we began to try to unpack where they are in the decision journey. And this is what the images on the screen typically look like. So in terms of understanding how far people were in making the decision, again, this is a population that had already been thinking about this. But wanting to understand, what's the next step that they take after they begin thinking about this? This is showing the distribution of their answers by type of screening: breast cancer screening, colon cancer screening, prostate cancer screening. A tendency for most of them to want to talk to the healthcare provider, but what we saw was that the men who were thinking about prostate cancer screening seemed more dependent on needing to talk to the doctor, had more questions, more uncertainties, which actually is pretty appropriate given the lack of evidence on that particular kind of screening. They answered questions that, as I mentioned, were directed at trying to understand what kinds of information was most important to them. What were the key questions that they wanted to answer? And they also had questions that asked them to describe how they like to get their information. Do they like to get it as pictures? Do they like to see numbers? Do they like to see videos? And depending on how they answered those questions, this system customized the resources that were put together for them. So for example, in this particular example, these were the 4 leading questions that the patient had identified, this particular patient. What are my options for getting screened? What are the health benefits of screening? What are the problems? And what are the costs and insurance coverage? A big issue in my country. And so these 4 boxes would not necessarily appear when you completed the survey, because you might identify a different set of questions. But also, when you click on that button for that particular question, the way the information is presented was customized to reflect what you said you wanted the information, in what format you wanted the information presented. So in this particular case, where the patient said they like to see the information visually, an infographic like this was presented. They gave them a sense of perspective about the magnitude of benefit, similar to an infographic that was shown in the earlier presentation. They could at any time go into a library of resources that are available on this site. So you can see here, for any variety of questions that they might have, that we had resources in all these different types of categories depending on how they like to see their information presented. Again, trying to understand, well, what are the next steps that you take in making this decision? This is an attempt to try to get some descriptive information about what choices they feel they have made. In the case of colon cancer screening, what kind of test they would like to get, and then what next steps they'd like to take. Whether they want to talk to the doctor, talk to family, etc. As I mentioned, we tried to get information about what questions were most important to them. Here you can see the questions that seem to be the most important up at the top. But you'll notice that women facing breast cancer screening tended to be a little more overconfident about what they needed to know. So you'll see a pattern here in terms of how they differed from men who were considering prostate cancer screening. On the emotional side, in terms of fears or worries, we tried to get a sense of what the leading concerns were that people had in terms of anxieties about screening, and you can see those listed here. Again, we also use this study as an opportunity to learn more about where people go to get information. In this case, you can see a fair amount of dependence on web-based information. We tried to get a better sense of how people's cognitive process worked. These are not the kind of advanced psychological studies that we've heard about earlier this afternoon. This is simply people's self-perception of how they go about making these decisions as answered on a survey. Nonetheless, to the extent that that's relevant, we saw that there was a large proportion of patients who felt that they made the decision by going through a cognitive process of weighing benefits and harms and deciding which treatment was best. In terms of confidence in the decision, a strong tendency for women considering breast cancer screening to feel like they knew what they needed to do. This is perhaps an American phenomenon. There's a tremendous cultural sense in my country that mammography is very effective and very important and a standard of care that actually is inconsistent with the randomized evidence from randomized controlled trials. And you can sort of see it played out here in these data. Limitations. There's a bunch of limitations listed here that are the kinds of traditional concerns you would hear mentioned in a health services research presentation. They have to do with issues of sampling, the metrics that were used for the study, the generalizability of the results, and so forth. But there's another kind of limitation that I think bears mentioning at a conference like this, is that it lacks the kind of nuanced, contextual understanding that we are talking about in this session. So if we think about complexity, systems thinking, as we've been discussing this afternoon, and the very contextual nature of how people make choices, that any one of those hundreds of patients that were in this study, each were going through their own decision journey. So a population-oriented survey like this really can't get into that level of nuance. Paul said we have to embrace complexity. Study designs like this are really not appropriate for dealing with that kind of level of complexity. Nonetheless, in terms of what conclusions come from this study, it looked like most patients did want help in finalizing their decision. It makes sense to think that people's attitudes and expectations about, in this case, cancer screening or potentially other complex decisions do depend on where people are in their decision journey. It seemed like a lot of people wanted to go about this process by weighing benefits and harms. I personally am not convinced that that's really how people make decisions, that they sit down with the mathematics and figure out what the effect sizes are and weigh it. In this study, American men eligible for prostate cancer screening seem less confident in screening than women who were thinking about mammography. And information technology, I think, can be helpful in reaching out to people, but we went into the study realizing that this is a very poor surrogate, a computer, for the kind of nuanced analysis of how people make decisions that's really needed. So I'll stop there. Thank you.